green light, perfect. Unfortunately, Anya can't be here today. She's at a bi-state meeting at Lake Maury.
Getting an award.
Perfect. We will not have a chair's report because she's not here, and I had a 2-hour session prepared, but George asked me not to do it. We have no minutes to approve, so we can strike that as well. So we're going to move right into the discussion on mental health integration. If Alice Silverman is ready. Is that, how are you?
I'm very well. Thank
Perfect.
Thought you had more to say.
I always have more to say, Sam. You want me to stall?
This is
No,
my
no, no,
colleague,
no.
Dr. Sue Deppy,
Oh,
and she is, we are both co-chairs of our Health Reform Committee in the Vermont Psychiatric Association, and she is the artist behind the PowerPoint presentation.
Perfect.
Hopefully simple enough that it
Press
won't
the arrow
overburden
to
anyone.
the right.
Press the arrow to the right is to
I'll
advance
go
it.
next slide.
Great. So,
Thank you, sir.
thank you so much for the opportunity to talk to you about psychiatry. And we, this presentation is the end result of a work group in the Vermont Psychiatric Association to put together what we thought would be most important for you to understand about what we do and how some of our recommendations going forward. So, some of you probably know a lot more about what outpatient private psychiatrists do and some of you less. So we're an invisible group in many ways. In the Department of Mental Health and designated agencies, psychiatrists are fairly well represented. And people know what they do and know what their problems are and their numbers are. But I don't even know how many outpatient psychiatrists there are in the state. I know our members. So we've done a survey, and we're going to present some of that information, and then we're happy to take any questions that you might have. So the summary of our presentation is in the first 2 pages. We're going to talk a lot about what private psychiatrists do, why we think it's important that the Green Mountain Board continue to support private practice psychiatrists as an important service in the state, and how psychiatrists are particularly well positioned for integration and collaboration, which is what we understand that you're very interested in. We're going to give you a snapshot of private practice. We're going to talk a lot about why access is a huge problem, which is something that we know about a great deal, but again, it's an invisible problem sometimes. We're going to talk about why access is such a problem, barriers to care, and recommendations. So you know that Vermont's been a leader in mental health and substance abuse treatment, and it has a strong tradition in community mental health. But there's a very skilled private practice community made up of psychiatrists, social workers, mental health counselors, substance abuse counselors, and psychologists. And again, that sector of the community often works behind the scenes of state government, but is very much influenced by how mental health is paid. So whether that sector is working well or not is sometimes outside of state government. We're sort of excited about the opportunity to bring that in and integrate it. So to talk a little bit about psychiatrists, we work in CMHCs, we work in the designated agencies. Psychiatrists work in residential settings, including substance abuse, rehabs. They work in intensive outpatient clinics like Seneca. They also work in the VA, college systems, corrections, and private organizations like Catholic Charities. And a large number of us work in solo, single, or group private practices. So the rest of this session is going to focus on private practice, because we understand that you have lots of information about other sectors. So, psychiatrists in outpatient private practice treat people with severe disorders and multiple comorbidities. Some of those patients are designated public sector patients. They've been in the state hospital, but they choose private care for any number of reasons. Lots of times institutional settings for certain populations are uncomfortable. And we also see people who have multiple comorbidities, often a lot of medical problems, because many of our referrals are from private family doctors, internists, neurologists, etc. The conditions that we treat are the same pretty much that people treat in the public sector. We are not necessarily in Vermont taking care of people who are just a little bit upset about their relationships. We're taking care of people with usually very severe disorders. Mood disorders, anxiety disorders, trauma, abuse, PTSD, dissociative disorders. We take care of schizophrenic patients. Again, I have a number of people in my practice who, for any number of reasons, don't go to the designated agencies, or who are getting case management there and prefer to see me privately, again, because there's more flexibility to individualize care, sometimes out of an institutional setting. And I'm calling a CMHC an institutional setting of sorts. We treat developmental disorders, behavior problems, school disorders, eating disorders, the organic brain disorders like dementia and delirium, and then we also work with families, couples issues dealing with normal adjustments like grief. Because we work very closely, often with referrals from primary care, the presence of a psychiatric illness often makes medical problems worse, so that primary care often wants to work closely with psychiatry, and the presence of a medical problem makes a psychiatric illness more difficult to treat. So these are complex patients that often require a lot of communication back and forth, and that's where issues around integration come up. The treatment of psychiatric and substance abuse disorders does lower overall healthcare costs, and I'll give you a case presentation later, and we can get you data on that. We didn't have the citations for that. Other people working on the citations, and they had some health problems, but there's data that shows if you treat these, and you all may know this, you lower costs. But they also lower the human services costs. So people who are treated before they go to prison save a lot of money. And at the moment, the prison is the largest provider of mental health services in the state.
Do you work in the prisons?
I work in the private. I have a private practice. I can tell you a little bit about me. I worked in the community mental health system. I came here 20 years ago as part of National Health Service Corps to work in St. Johnsbury since it's underserved, and that was a payback, and I stayed. So I started in the community mental health system. I worked part-time for them, and part-time was employed by NVRH, which is our local community hospital, doing a consultation service, inpatient and outpatient. I switched full-time over to the consultation practice, and it was too expensive, and it was closed about 6 years ago. So we lost too much money. So that tells you a little bit. I've been asked to do consults in the prison, and the model of care there is a 10-minute session, and I felt that that was not an adequate way to treat psychiatric patients. So they were desperate, and I've been called, and I considered it, but declined, based on concerns I had about quality. So psychiatrists vary in what they do, but they provide a variety of both short and long-term psychotherapies. Much like social workers, mental health counselors, and psychologists, psychiatrists provide the range of psychotherapies. They do a lot of supportive work, psychoeducation. Cognitive behavioral is the buzzword these days, and psychiatrists do that as well. They do interpersonal therapy, more long-term, insight-oriented treatment, and try, I think, to tailor it to patient needs. They work with children, families, groups, couples, and individuals, depending on the practitioner. And the interesting thing about the psychotherapies are, whenever we've been able to get the data and to study them, we find that all psychotherapies are effective, and that the crucial thing is the relationship between the fit between the provider and the patient. So even though there's some evidence-based medicine at the moment about cognitive behavioral therapy, it's kind of just where they're shining the light. It's easy to study that. It's short-term by its definition, and you don't necessarily see long-term outcomes. And it works for people who like cognitive behavioral therapy, and it doesn't work for people who don't. So even though you have evidence-based medicine that tells you cognitive behavioral therapy works for depression, if someone is not interested in doing a lot of homework, that may not be the right fit for them. So what we have really come to find is we have to get the kind of studies and information systems that let us look at the data, is that it's the patient-therapist fit. The thing that I think our whole group really wanted to emphasize was that the private practice model is not the only model, and that we support a network of services available, but that it's one important sector of mental health care that provides for flexibility of treatment. and a diversity of options so that patients can choose. What happens in the designated agencies is one model gets kind of a lot of attention, and then that's what's mandated, and that's what they hire a supervisor who is interested in doing that. And then if the patient doesn't fit that, there's no place to go. Typically, clinicians are assigned based on availability, so that people don't really have a lot of flexibility on who treats them. So the really nice thing about private practice model is that it provides therapeutic flexibility and diversity of options, and that includes psychiatry, social work, and psychology, mental health counselors, and substance abuse counselors. And nurse practitioners.
Yeah.
So, in addition to psychotherapy, private practice psychiatrists do a lot of other things. We treat people right out of the hospital, so even though they're not coming out of like the state hospital public setting, they come out of private settings and they're equally sick. Someone with a major depression who is not qualified yet for public sector care is very sick, they come out, and they come often to a private psychiatrist. So private psychiatrists are often putting together treatment plans in the community. One of the things that we'll get to is there are not enough of us, and at this point I get referrals from family members who've been discharged from hospitals without a discharge plan. So, with really quite sick people. But for those people that we do manage to serve, we do intensive care, crisis management. We're working with housing, we're working with getting them established in medical care, we're doing a lot of intensive care, we're multifunctional. On the other end, we're often hospitalizing people. Again, through the designated agencies and the state hospital public system, you go through the mental health center, but the bulk of hospitalizations are in the outpatient sector to the community hospitals, and psychiatrists are involved in that. We are doctors, we do lab work, we prescribe medications, we work closely with medical colleagues, managing difficult people with comorbidities, and we work with our non-medical therapy colleagues. Sometimes doing what's called split treatment, where we do the pharmacotherapy and the non-doctor therapist is doing the counseling. A number of us work by ourselves. I work independently. Other psychiatrists in private practice work with other clinicians. Some of us work full-time, many work part-time and do salaried work on the side. They do private practice as their hobby and get paid through some salaried position. Really, that's what people say. They do it because they love it, but they can't make a living. So they have some salaried work. So there are a lot of part-time psychiatrists. We do evaluations diagnostically, psychotherapies, medication, and case management. We are, in private practice, there are people who have subspecialty areas. There are a number of people who do forensic work. They're often hired by the state to do evaluations of people who are facing commitment. There are child and adolescent psychiatrists, geriatric specialists, some people who do psychoanalysis.
Forensic can cover the legal, the criminal, and the prison stuff too sometimes. I was going to say that forensic can also cover the prison. Some of those folks do evaluations in the prisons or in the state hospital when there's a criminal issue.
There are people who specialize in trauma, spirituality, substance abuse, and very much treatment varies based on the patient's needs in terms of duration and intensity. Our training in psychiatry is broad. We go to medical school for 4 years, and then we do 4 years of a residency training in psychiatry, and then people go on to do subspecialty work in child beyond that, or the other subspecialties. We have a background in neurology and physiology, pharmacology, and psychotherapies as part of our training. In that regard, we're well positioned for integrative functioning. We move easily among our medical colleagues, our mental health, and human service colleagues. We are frequently in a consultative mode, and we provide supervision to one another, to other mental health clinicians, and to trainees. One of the issues that there's been a move in the private sector to what's called split treatment, which is, well, where psychiatrists are doing just medication and other people are doing the counseling. And some of us thought that that was because it was less expensive, why it was, and it turns out that there's some, so the question is that less expensive? Insurance company practices suggest that it would be. That is, they often deny psychiatrists the ability to do psychotherapy. They say all you can do is psychopharmacology. we won't pay for psychotherapy for you. So it looks like, well, maybe they thought that that was more expensive, and I actually thought it was more expensive until we did some research. And this is an article in the American Journal of Psychiatry, 1999, about psychiatry is cost-effective, and they did an analysis of integrated treatment, which means the psychiatrist provides the medication and the psychotherapy. That's what integrated combined treatment is versus split. And surprisingly, the results showed that psychiatrists providing both therapy and medication is most cost-effective, and that 5 medication visits and 10 therapy visits split between a psychiatrist and a therapist were 10% more expensive than 10 psychiatrist integrated visits. I was surprised. The prevailing thought is that somehow psychiatrists are too expensive. In addition to the financial benefit, combined treatment by psychiatrists has other benefits. It's often more effective for certain groups of patients. And I wanted to give an example from someone from my practice who had complex PTSD based on early abuse, multiple anxiety problems, what's called somatoform spectrum disorders, which is whenever she was under stress, she got new physical symptoms. Family doctors see these patients a lot with headaches, GI problems, exacerbations of asthma, so the sort of psychosomatic illnesses. And when she came to me, she came to me 5 years ago, referred by her nurse practitioner in the private sector who was medicating her. She came to me on 10 medications from every class of drug, 2 from every class of drug, and he was understandably concerned she wasn't getting better. In addition, she was seeing her primary care doctor maybe every week, every other week, missing work. She had a fairly responsible job in a bank, but because of medical problems and a tendency to somaticize, missing lots of work at risk of losing her job, and her primary care doctor, she was really puzzling. So I did a consultation 5 years ago. She transferred her, and she was seeing a therapist as well. So there was a therapist. But she dropped out of therapy, which is often a problem with split treatment, so that you're not getting an integrated treatment because the person is working, they have children, they have to go to the psychopharmacologist, they have to go to the psychotherapist, their family doctor. After a while, you can't maintain your life seeing so many people. In addition, sometimes there's some resistance to looking at the other causes. It's sometimes easier to think, just give me the pill. But in this instance, it was causing all kinds of problems. Half of the reasons that she went to her primary care doctor were adverse effects from the psychotropic she was being prescribed. She had physical problems. So, it's one of those terrible cases where everyone was trying their best with someone who wasn't well, but they weren't integrated. I did a consultation. Slowly over a year, we removed all the medicines. Surprisingly, a lot of her side effects improved. She started to do better. And I prescribed psychotherapy because she had psychosocial problems. She was living with an alcoholic. That was a major problem. I got her connected with support for people who have alcoholics in their family, and we looked at some of her abuse history. I'm still treating her. She's not on any psychotropic medicine, or just much less. She hasn't seen her family doctor in a year. She's working full time. It's been a long-term treatment, though. I see her, and we're moving along. So it's an example, though, of someone who, in an integrated treatment in a private practice model, who was costing a lot of money in medical care and not really getting anywhere, I think did better with a psychiatric provider who had a diagnostic confidence so that I didn't have to over-medicate and could work with her in determining the appropriate psychosocial treatment. And again, I do use medications with her, but sparingly. So for certain patients, combined and integrated treatment is a very powerful modality in the range of care options. That is not to say that social workers and psychologists don't do a good job in treating patients and that everyone has to see a psychiatrist. That's not the case. But in selected groups, it's really a very powerful modality. And it's cost effective.
That group of people with trauma and huge amounts of physical issues is huge. I mean, the data supports it as far as I know. And those people are often very high utilizers. Certainly they are in my practice. And they're at risk for things like obesity and a whole bunch of other things like fibromyalgia and what have you.
So there is a huge access problem in mental health, and you may know about that. But there's some data that shows that from 1998 to 2007, total general medical expenditures rose, 361 billion to 592 billion. This is national data, and I have the citation. It didn't show up on this slide. But mental health expenditures over that same period have gone up just a fraction. So I think, as you're thinking about containing costs, medical costs have risen, but mental health expenditures have not. And this slide really shows that nicely. The psychotherapy proportion of mental health expenditures has actually gone down. And again, that's the private insurance push for psychopharm, drug treatment. 71% in 1998, 45% in 2007. The mean expenditure for a therapy visit has gone down. We're going to talk a little bit about this later. From 122, and again, this is national averages, from 122 per visit to 94.59 per visit. And the mean annual number of therapy visits have declined from 9.7 to 7.9. And this has been a direct effort of managed care and private sector insurance. This is an article that talks about a critical shortage of psychiatrists in the United States. It's from Psychiatric News. And I want to talk a little bit about the causes of the access problem, then we'll get to the solutions. So there's been a downward pressure on reimbursement over the past 15 years, such that fewer psychiatrists are willing to practice privately. I just did a national presentation at the American Psychiatric Association about a private psychiatric practice, and it's really rare. It's becoming a rare kind of thing. I think in Vermont, people are willing to accept less money in general because it's a quality of life place to live in all areas of professional life. But this downward pressure is nationwide, but it's also in Vermont. In addition, there's been almost the complete elimination of outpatient programs from the designated agencies. When I started 20 years ago at Northeast Kingdom Human Services, I worked entirely with the adult outpatient population. And I had a colleague who spent half his time, and we had an array of therapists. And because of funding issues and overhead, that has shrunk drastically. I don't know if there's even an outpatient therapist. They just do consultation and referral back to the primary care docs. I have occasionally the opportunity to work with residents. And there was a psychiatry resident from UVM, and you're excited about people training in Vermont who'll stay and work in Vermont because it's a great place to live. And she told me that her supervisors advised her not to go into private practice because it was not financially viable. So these are our young colleagues who are going to replace those of us who are moving towards retirement age. They're being advised that it's not viable. We did a VPA survey. We have 128 members. Most people have said that the pressure from insurance and oppressive management practices have led them to shift out of private practice and into more salaried positions. Those people who are in private practice spoke very poignantly about the number of phone calls they get of patients that they can't meet. I've kept track over the last 2 months, and I have 2 to 3 referrals of desperate family members or patients a week that I can't serve. And this is not unusual. And I thought, well, maybe this is just the Northeast Kingdom. And I'm a solo doc out there, and it's a less affluent community. This is across the board in Burlington, Montpelier, all across the state. Many of the private practitioners won't participate in insurance companies because of managed care and oppressive insurance practices. I participate with it. Other people do, but many people have elected not to. The problems with repeated prior auths for routine care. I mean, getting authorization for routine care and medications, unfair denials, high copays and deductibles that end up being passed on to the provider have led many people not to participate. These waste time, they impede care. Other barriers to care include the fact that patients move between settings that are self-contained. Our system is currently a silo system. And the usable funding does not move with the patients. This is not patient-centered care, it's silo-centered care. So as you're thinking about integration, we want to think about a payment system that is integrated so that people can move from the state hospital to any variety of other service as needed that's patient-centered and not insurance silo-centered, which is really what we're doing right now. Another barrier is the closing of programs, again, I think because of funding issues. So there are no specialized programs anymore for eating disorders. That's a high mortality illness. People die from that like they die from cardiac disease. It would be unthinkable not to have cardiac surgery. We don't have an eating disorders inpatient setting. We did it, there was one at Dartmouth, and I think it lost too much money. Dissociative disorders are another problem, long-term residential treatment sometimes for trauma. The public-private funding is an artificial split. Patients move back and forth between different settings, and it's often a barrier to care. So what we recommend are the following: that we support public-private collaborative efforts that are patient-centered, not system-centered. If we want integration, we want a system that allows people to move around the system as they need, not as the funding defines. At present, collaboration and consultation between me and my primary colleagues is not funded, so it's hard to get primary care people to talk to me during the day because they have to make they have to earn their money. You know, they have to hit a quota of patients seen. And for me, I mean, if I'm going to be talking on the phone to people for a couple hours a day, I'm going to choose to do it. You know, I don't have a lot of medical school debt. I was in the National Health Service. It's not easy for me to get a colleague right out of school to say I'm going to spend 3 hours a day doing non-reimbursed time so that I do good care. So funding, collaboration, and consultation. If you want collaboration to happen, it should be paid for. Fund co-located mental health and primary care services. There's been some efforts, I think, that are great to have mental health people in primary care clinics. At present, there are nurse practitioners in those clinics. I'm not sure that there's psychiatry access. What happens is they refer those patients to me that are too difficult privately. And often that's hard for me to do because, again, it requires a lot of collaboration. I'm not in the system. I don't get paid for it. They don't fund psychiatrists in those settings, but then there aren't enough private psychiatrists to see those people because it's a money loser.
My understanding is that that's happened in parts of the Chittenden County systems, that there was a psychiatrist in the primary care clinics who's no longer there because it's not a moneymaker. And the same thing for the adult outpatient department in the Department of Psychiatry. I don't know for sure, but I believe that was for the same reason. It almost doesn't exist as far as having psychiatrists see a lot of patients because it's not paid.
So it's very exciting to think about having psychiatrists co-located in mental health facilities and paying for that as a certain model of care, as well as having private sector psychiatrists. It's not one or the other. Co-location is a great idea, as well having medical people in mental health designated agencies. Psychiatric patients have a hard time getting care. They're not attractive patients sometimes, and depending on the primary care doctor, they're more or less comfortable. So having medical care in the designated agencies would be lovely, and I think excellent. These are sick people, they die earlier, they don't get care. We talked about funding work that fosters integration. That probably includes, you know, a pay rate for indirect care. There is a code in CPT for medical record review, writing letters, talking with other people, but no one reimburses it. So there's a code, but you can't, you know, insurance companies don't reimburse it, Medicaid doesn't reimburse it, Medicare doesn't reimburse it. It should be reimbursed. The other issue is working towards a triage and coordination that includes the private sector. So all these invisible people who are on their own. In the private sector, it would be lovely to think about the Department of Mental Health seeing adult outpatients as part of what they do, and or in the larger envisioning of integration, having some way that these people are not on their own, just desperately trying to get care. It'd be lovely if we had triage and coordination. Additional recommendations to improve access and care is fair, sustainable, predictable reimbursement for mental health and substance abuse services.
Quick comment on that. I have somebody who, my office manager and I just got back claims from Medicaid. And all of a sudden, these sessions for this one person who I'm working with quite intensively because she needs it and she's in a terrible marriage and been suicidal and so on, suddenly not being reimbursed. Not eligible for Medicaid is what my office manager found out when she went on the website. And because of income guidelines, because of the fact that our system is all fractured up, a lot of those people go on and off and on and off. As a clinician, it can just tear you up thinking, I really need to keep seeing this person once a week or even sometimes more often than that, but I'm getting killed. I'm not going to get paid for it and I can't charge the patient. And that often happens with other insurances as well. That predictability was something one of our colleagues in the committee said is crucial. And of course, fair and sustainable, enough to live on, which I know you guys have as a goal anyway for reimbursement.
Thank you. In the new healthcare reform world, we'd like for the system to trust practitioners to make patient-centered care and decisions rather than using third-party micromanagement. Reimbursing telepsychiatry would be great for people who are really isolated, phone calls. And it would be really nice to have a central uniform credentialing process based on licensure. As it stands now, I have to credential with 1 million private insurance companies. It's time-consuming, simplified license. I mean, if I'm licensed in the state of Vermont, that should be adequate. But if it's not, at least uniform and central credentialing. The other obstacle sometimes is people can't get paid if they see a psychotherapist and a psychopharmacologist the same day. So if people are co-located, that's something that's good for integration, but that's a disintegrating policy. You can't see 2 providers in the same day. That obviously is an easy thing to fix.
Or 2 Medicare consultations in a hospital.
I'm in Vermont because of the National Health Service Corps. It was an effective policy to get doctors in underserved areas. They paid for medical school. I came here and I stayed. So having a statewide loan repayment program to encourage recruitment and retention of psychiatrists is something to think about. I mean, there's a shortage nationwide, but Vermont is a great place to live. Why don't we get the best people here by offering them loan repayment? So in closing, we became involved in healthcare reform, I think, because psychiatrists and psychiatry patients are often noticing the problems early on. We're the canaries in the system. It wasn't working for us. Managed care wasn't working for us a long time ago, and then the other specialties started to notice it. But we've endorsed universal, single-payer health insurance, decoupled from employment. It minimizes practitioners' administrative burdens, allows patients to choose whom to see, and empowers patients and doctors to make clinical decisions. So we are very excited about the work that you're doing. We think that it will improve care for our patients and Vermonters in general, and we look forward to partnering with you as Vermont moves forward towards this important goal. We thank you for your efforts.
Thank you. Questions, gang?
Yeah, I had a couple. I can find them here real quick.
Well, I've got
Yeah,
me too.
So how often, I wonder how do you decide when to close your practice? Meaning, I know as a family doctor, my decision is based on how long it takes to get in to see for a physical, or how long it takes to get in to see me for a routine visit. And you get to a final threshold, and you kind of look at your panel and you say, that's it, I got to close my practice. And you hope that, you've added a partner and the people that you're trying to serve have, get served. How does that work in your specialty? Like, how do you decide you can or can't see another patient? Now, because we know in fee-for-service, we know what it's done. I know what it's done to me. It's made me very productive. It made me see 30 patients a day instead of 20 patients a day, or, what I want to see. So how does that work? How does that work in you?
I think that it works differently for different people, so I can't speak for all of us. I can speak for myself.
Yeah.
That having done this for 20 years and being in an underserved area, when I'm ready to stop doing psychiatry, I know that I'm overworking. When I'm ready to leave, literally, I'm thinking I'm not enjoying my work anymore. I dread Monday. So what I did is I overworked for years. Mm-hmm. I just stretched my day. I talk to every patient. I don't have a secretary. So everyone who calls, I speak to. So I just, I'd work very long hours, not take vacations, and that was a recipe for burnout. So I knew when I was envious of my patients on disability, I had a problem. But how nice it must be not to work. I think we all just you do the best you can. I became an advocate because I was aware of how many people weren't being served, and I knew I couldn't personally serve them. The system had to be changed.
Is there any other supportive organization other than the VPA for the independent practicing psychiatrist? For independently practicing family doctors in the state, there are a couple of organizations that support them. Do you have any others?
Which are they, Alan?
IPA? Well, like Health First, like when CHP closed, now there's Primary Care Partners.
Oh, right,
yeah.
okay.
So
No,
do you
and
have
the
anything
VPA
other than VPA?
The VPA is all psychiatrists, and so within the VPA there is a private practice
There is.
community, but there are no other organizations that support private practitioners. But it's a pretty desperate situation. I mean, I think, and it's invisible in some ways, and I think everyone just does the best they can. Some people, I think, try to develop coalitions with other therapists and work together on site. I think that's a model that allows psychiatrists to be more productive in certain communities. When a lot of people don't do split treatment that well with people who aren't co-located, because there are really hazards with that. There's not a lot of opportunity to put your care together. And I mean, it works for some people, I think, who work well together and develop a relationship. But I don't know how people, I think it's an individual choice. I mean, you hit a point of diminishing returns if you see too many people in this kind of work. You know, I mean, I'm seeing sick people. If I cut the time that I'm seeing them, I see the bad results in terms of outcomes.
I think it is very individual, because as Alan knows, I had a chronic illness for years, and I've always worked part-time, and you sort of figure out where are you too stressed out. And one of the things that's the most stressful for me, and I don't think any of us on the committee would argue with this, is that the system itself of insurance and payment and managed care, as you all know, conspires to make you enraged, because it gets in the way so badly of doing what you want to do for patients. To spend 15 minutes doing a Medicare D pre-cert on a routine antidepressant every year, or even a Medicaid one. You know, when the only question they're going to ask you is, are you giving a monoamine oxidase inhibitor with this antidepressant? And you're like, no, because that would be malpractice. Thank you very much. I mean, that's a waste of time. So the wastefulness of it, when you know you could be doing other things with your time, I think for me, part of my motivation for the advocacy is the effects of these things on the clinicians, the physicians and so on. And that indirectly affects patients. So I think everybody, with response to your question, Alan, it is individual. I did it differently than Alice. I don't have the capability to work that many hours. But and the other thing is, when you first asked it, I thought, how am I going to close my practice when I retire? And that's frightening, because who's going to take those people when there are very few new psychiatrists coming in private practice? I don't know what I'm going to do, and nor does Alice. So I'm really hoping this single payer thing goes really well, so we'll have lots of psychiatrists.
Well, that relates to the most important question I've got. In your other barriers for care section, you use the phrase, move payments from silos to patients. Can you bring that to life for us a little bit?
Yeah. When you think of kind of an integrated system, a hospital is a good example of an integrated system. People can go to radiology, they can go to the intensive care unit, they can be moved down to the regular floor, and it's seamless, right? So the idea is you want a healthcare system that allows for that kind of movement. So right now, if you're in the community mental health center and you're someone who met criteria for the CRT program, which is the chronically and severely mentally ill, and you've been getting care at the mental health center, but you want to have options for other care. You can't get your case management there and see someone in the privately, let's say, for let's say psychotherapy. So you can't move back and forth. If I'm seeing someone, who is had a first hospitalization out of state, has moved to the area, and is seeing me individually, I'd like to get him into case management services in the mental health center. I can't do it because he's seeing me. It doesn't move. It's not patient-centered. he's chronically ill, he's seeing me in a private practice, he would benefit from all the case management funded services in the mental health center, but because of he's seeing me, he can't access that. So that's not patient-centered, it's silo, private practice, mental health center. But patients can access services from a range of services as their needs change.
Some of that's breaking down. I have been, in the last couple of years, been able to engage some case management at Howard Center, because I'm in Colchester. So some of it's beginning to break down, but the funding is probably not really breaking down.
So there are these community beds that I think now are going to become available. This is now maybe changing with more funding, but there'd be a step between outpatient care, let's say, in hospitals. So someone might need to be just in a supervised setting, they're suicidal, but they may not need a psych hospitalization. You want to avoid that if you can. It's kind of stigmatizing. So I couldn't access the community care beds because I was a private psychiatrist and that's a public bed. As opposed to in a hospital. You can go to the ICU if you get sick, and then you can go back down to the floor. So that's the idea.
And even the difference with Medicare D, which is like one of my least favorite programs on the face of the planet, because it makes no sense to have all that private insurance leeching off of the public system. But anyway, you know, patients who they got their care paid for in the hospital, and they come out and a particular drug isn't available on their insurance plan. You know, boom, you've got a problem, and you've got a huge scramble to try to get the care to continue in a perfectly reasonable way.
Right, it's also insurance. That's the crazy thing with insurance. You know, you have MVP, and MVP allows this, but then you change your job, and you're in Blue Cross Blue Shield, and Blue Cross Shield allows this. Yeah. And I'm not in that, so they can't see me. That's siloed in terms of insurance companies. That's another silo system.
Yeah. And because I don't do commercial insurance at all, including Blue Cross Blue Shield, because of Magellan, I'm not even doing Catamount. So if we go to the exchanges, I may lose a bunch of people who are on VHAP and not be able to see them because I'm not willing to put up with the abuse in that system.
Karen?
I have 4 questions, and you've been very helpful in giving us a good feel for some of the current conundrums. I want to leap ahead a little bit into the New World Order, and so my questions are the following. First is, if we were to have a more seamless integrated system, how would you think about outcomes for the patients that you serve? In other words, if we were to go more towards a global payment system and it's just up to you and colleagues to work together to improve health, in terms of improving mental health, what would you refer us to as ways that we could actually give you a bag of money with the outcome being improved health? So how would we think about the mental health component of improved health? Wellness, improve from some baseline, some functional status assessment. Help us in that regard.
I could respond that I think I see mental health as a little bit, I see that the current system that we have of care options is a good one. I like to maintain that diversity of care options. Payment reform and global payments, I see not accomplishing a lot if you take mental health and you put it in. It's kind of managed care to me again in a certain kind of way that I think that
it's just saying to manage the care, but just show how the patients improve.
We're not in an integrated enough system, and I'm not sure that I want to be integrated. I think I'd like to see integration. I mean, I want to be integrated within different models of integration, so I'd still like a diversity of options. So I'd like to see primary care practices that are going to do mental health, because they serve a lot of people to exist, and they can get a global payment because they're working together. I still like the idea of being able to see someone separate from that environment, because I think different patients need different things. There's some people who'll never come see me, and I'd like them to get their care in their primary care clinic. They're never going to come see me. Those people who are not going to do so well in a short-term model, which is what is happening in the medical clinics. So I know you're thinking payment reform and bundled sort of payments, but I'm not exactly sure that I know how to
Actually, my question is a little different.
Okay.
It's saying you are now part of, we've fixed all of this mess with there's a diversity of options in terms of treatments and settings, and you're now part of the seamless team. involved when you need to be and you're not involved when you don't need to be. How would you help us know that the patient's health and mental health has improved to be able to continue to refill the coffers for not just you, but for you and colleagues in a seamless system? What outcomes would you want us to use and adopt for the mental health or mental wellness component?
That's a very broad question. I need to think about that. I think I don't have a quick answer.
That would be helpful for us.
Yeah.
And I don't think
we probably would not have a broad stroke because it's such a big umbrella.
Right.
You know, but I might think of employment, less disability. You know, I mean, if we're thinking broadly,
That's,
you know,
the kind of
employment,
thing.
Yeah,
decrease in disability rates,
perhaps
due to mental
suicide
illness,
rates, perhaps.
decreased hospitalization. Again, it's a broad.
Yeah, so in a way, we're asking you and colleagues to help us with that one because you're the experts.
Yeah,
And
I
the
mean, I'd be
second-
hoping disability rates would go down, employment would go up, higher functioning.
And measured by what? Higher functioning? How would you literally do that?
I know, I certainly
If
would
you
need
ask me,
some
I can
input
tell
from-
you, I
Yeah.
hate personally, you know, checklists because people are more complicated than checklists. So, you know, it's not a simple thing, but I can tell you this person that I'm seeing is functioning much better. But
we
how would we prove it to
Yeah.
you? She's still employed, she's not on disability, she's seeing her primary care doctor less for some psychosomatic problems. And again, it would vary based on any given person. Less substance abuse, less incarceration rates, you know, I mean, bigger.
Good, well, that line of thinking would be helpful for us
That would be,
to have some more
I'd like to have some more
help with.
discussion.
The
on that.
other quick questions are, you made references to some changes from 1998 to 2007. Can you just help us with some baselines, like what sorts of mental health professional ratios are there in the country and compared to Vermont? And what are the access questions, are they exacerbated by one's rural setting or other factors? In other words, what can you be a little bit, go to the next level in terms of the access problems and helping us with what's the norm, what would you like it to be, and where are we now?
You want me to take a step, first part?
I don't have that data. I think we could find some of that data where we compare nationally, but I think my sense of it is that, from talking to my colleagues, is that access is a problem both in rural and urban settings, and that it's because there's not enough numbers and that practices are closed, even in urban settings. So in Burlington, which is a very urban, there's a university, people are having trouble getting care there because there's a global shortage. There's not enough psychiatrists to serve the people who need to be served in rural and urban areas. And how that compares to the rest of the country, we could use some help getting that information. We don't actually have that.
I think it would be helpful for us.
To know how we compare.
Same as we're looking at other types of providers and their adequacy and so forth. The third,
Dr. Hein, I think there is some data about number of psychiatrists in Vermont that's a little misleading, because I've seen some evidence that, or some numbers that say we have quite a few psychiatrists per capita. The problem is that a lot of the folks that are sort of registered as Vermont psychiatrists are with institutions where they're not available to most patients. So they're with Brattleboro, or they're with Dartmouth, or they're with the VA, or they're with Fletcher Allen, and most of those people are not taking new patients because they have a defined role in their institution. So the stats that may look good for number of psychiatrists in Vermont, and I think I have seen that number somewhere, it really isn't very good because people are not available to take more patients. The other comment I want to make is that for 20 or 30, I don't know, maybe if it goes back 30 years, maybe Ken can remember, I've been in practice for more than 20 years, and the statistics on child psychiatry has been desperate for that time at least. And geriatric psychiatry has been, in my gestalt of it has been that it's been quite underserved. That nursing homes and other folks and primary care docs would love to have some more help there. But again, it's a question of the time you put in versus what you get paid for it. And you know, I know Terry Rabinowitz did some neat stuff at Fletcher Allen with nursing homes near and far, where he would do telepsychiatry. He'd have nursing staff on the other end, prepare the case, give him the particulars, and then he'd interview the patient online. And it was pretty helpful. But I think there's funding issues and there's availability issues on the geriatric piece for ambulatory and nursing home as well. But I don't have actual numbers for that.
There's two more quick questions. One is Ken was kind enough to share the history of mental health parity in Vermont, which is a really exciting read. I'm just wondering if you or maybe Ken could comment on where you see any tweaks that are needed. The story is a compelling one. Vermont was on the forefront. What's left to be done around mental health and substance abuse parity?
Well, I think that there's parity, and then there's the implementation of parity. If you don't have enough practitioners to serve people, and they can't move because there are barriers, you have parity in legislation, but it's not actualized. So I think the system, so that people can move about and access the resources, it makes parity to make it functional.
To be honest, I think that one of the hugest barriers to actualizing parity is insurance. I can't wait for a single payer system that honors the fact of the work that you're doing. And I think that's going to draw psychiatrists to Vermont. I really do. I mean, who wouldn't want to work in an environment where you're not harassed and belittled by somebody who has less training than you do? And you can take care of your patients and do what you care about. So I honestly think that getting rid of the multiple insurance companies and the managed care component is huge in terms of, drawing psychiatrists for the access problem, but also in terms of really actualizing parity. Because when we passed the parity bill, and Ken, I'm sure, can speak to this better than I can, one of the compromises was we couldn't get rid of managed care. If some of us had had our way, we would have eliminated all the carve-outs and managed care and special treatment for mental health. And that didn't happen.
My last question is, can you look to another state or region or anywhere where you see this working well, sort of a model?
They're looking to us.
Yeah.
So at my national presentation, Oregon and Vermont are considered the leaders. So they're hoping we have something for them to do. As of now, again, in psychiatry. So at my national conference, I'm not hearing of innovative, exciting things that are happening. People are doing this integrated thing with docs, psychiatrists in primary care practices, and that's now a new niche that I think has some value. And bringing actually psychiatrists into primary care to consult and be available, because that's where a lot of work is happening. So that's a new addition, and that's happening in some states more than others.
My last question has to do with prisons. I can't recall who was here to say it, but I think the number was something like 25% in that order of magnitude of people in prisons.
Had psychiatric problems?
Yes.
I think it's higher.
It's 50.
50?
I think
Well,
it's
it was a
much
big
higher.
number.
Huge
All
number.
right.
And if you had substance abuse,
Yeah.
Oh, okay.
I consider
No, I
substance
got
abuse a
it.
psychiatric
No.
problem.
It is a big problem. And you said that the basic approach is 10-minute cycling sessions. How would you handle this? What would you do? And relate that to the changes that are supposed to happen in the mental health system as a result of the new funding in the legislature this year.
Yeah, I think, having a for-profit entity administer your psychiatric benefits in the prisons is a problem. I mean, the profit motive is a problem there, and there's no oversight. So I think that's a problem.
How would you handle it?
I would have, this is a little, I'm sort of a private practitioner, I don't know that world well enough.
We understand. But
You
we're
know,
just
but
trying to
in
look
an
at this from
ideal
different
world, you'd
directions.
have those services run and administered by people who are caring about treating this population and allow for good quality care. Mental health care in a prison and medical care in a prison. I mean, prison's a hard place, so prevention is the bigger thing I see. I mean, that's where I would be putting my But for those people who are currently in that setting, providing good, humane, high-quality care, medical and psychiatric.
And then tag teaming directly to the outside when somebody's released.
And then making sure this
to a
follow-up.
system that has good follow-up, yeah. And I wonder if some of the folks who are actually working in the prison might be useful to talk to KidCon, because we're much less knowledgeable, I know.
Okay.
I think Alice's comment about prevention is huge, though. I mean, there's some really exciting stuff going on with restorative practices in schools and human services and stuff, and I've been teaching in that world on my emotion stuff. And phenomenal statistics about less bullying, better school climate, da-da-da-da-da. That would be a heck of an investment to make if we could facilitate that. It's huge. There's a whole town in Hull, UK is a depressed area that in about 2 years turned their entire school around from special measures to honors and are raising healthy kids. It's just awesome. There's some really cool stuff out
Well,
there.
I mean, every inmate represents about $45,000.
It's expensive.
Yeah.
Yeah.
Wouldn't take too much to do some of that scripting early. If we have to do it through the schools, then let's do it with schools and parents and everybody.
But what I also see is the adults who can't get care, so adults with substance abuse and adults with psychiatric illness, their children are at risk.
Yeah.
So I see a good community-based access to mental health care as being a very useful investment in the children of those parents. I mean, if you come from a substance abuse parent and you're neglected, you're at really high risk, if you're a guy in particular, to go to jail. So early intervention on the parents.
Besides, if Alan's recollection is better than mine, it usually is. What do we got, a couple thousand inmates? You're talking about 1,000 people in Vermont prisons that have some kind of difficulty. This is a major issue.
It is. Yeah.
Okay.
It's a huge issue.
We all set? Well, thank you.
Thank you so much.
Thank you.
Rick Barnett is next up. How are you, Rick?
Good, good. Should I don't have a PowerPoint or anything. I can
Just come on up and spend some time with us.
Thanks for having me.
Thanks for coming. We appreciate it.
I heard about this at the last minute, so I'm not as prepared as that very extensive PowerPoint. But I did get a chance briefly this morning to review it, and having heard it, it echoes a lot of what I might be presenting. So I'll be pretty brief in echoing a lot of what Dr. Silverman has shared with you. You can substitute the word Vermont Psychiatric Association with Vermont Psychological Association. Every time you see psychiatrist in there, for the most part, you can apply psychologist in there. It's very, very similar issues. There's some exceptions to that, obviously. But I am currently the president of the Vermont Psychological Association. I've served on the board with them for the last 4 or 5 years. Currently as president, this is my last year as president. And so I caught wind of this at the last minute and pulled together some information from some of our other board members. Actually, the director of inpatient psychiatry at Rutland Regional was the one who's a board member of ours, turned me on to this meeting. He sent me an email saying, "Hey Rick, are you going to be at this meeting?" I said, "Oh, I wasn't aware of it." So I'm happy to be here. I did send Sam Lacey a brief bulleted outline. I'm not sure. Oh, that's okay, good.
Should be up there.
Okay, good. So you got that. And as you can see, a lot of it just echoes what Dr. Silverman has said already in her presentation. I guess I also want to say thank you to all the board members of this board for, I'm just in awe of the task before you and all the work you have to do. And I'm a relative neophyte when it comes to any of the history of mental health and parity and all these issues, but I've been, I guess, in the trenches long enough now. I feel comfortable sharing a few thoughts with you, and thank you for the work that you do. So the first bulleted point that I have there is really something that Alex Forbes, who's on our board, pointed out to me, and Alice, Dr. Silverman said, is that really I want to focus on the role of independent practitioners in this whole reform process. So you have mental health, which is a small portion of the overall healthcare expenditures, and then you have independent practitioners who are even maybe a smaller portion of that, but that doesn't mean that our impact isn't significant. And I think that, you know, my presence here and Dr. Silverman and Rilla Murray from the Social Work Association speaking as a voice on behalf of all independent practitioners is extremely important, because we all think of like designated agencies, federally qualified health centers, mental health agencies. We think of that when it comes to mental health, and we don't think about all the work that's done, you know, invisibly by those of us in private practice. Seeing, you know, I see about 40 people a week privately. That's quite a significant chunk of people. And I can imagine that replicated, you know, in all of us who are in private practice. So I'm speaking on behalf of, hopefully on behalf of all of us. So we are, I mean, going to Dr. Hines' question about outcomes, you know, I could speak very easily to that. You could not reinvent the wheel and look at any other healthcare measures that you would have to measure outcomes in medical practices. But, you know, everything that Dr. Silverman pointed to, and certainly we can provide that information to the board. But we could do checklists. We could just look at pre-treatment and see how often were they going to see their primary care physician, how often were they being admitted for psychiatric inpatient, how often are they being incarcerated, how often are they, you know, utilizing some services costing the taxpayer dollar, and then look at post-treatment and see if, okay, have their overall health measures, you know, diabetes or any other chronic health condition, have they improved? Are they not seeing their primary care physician as much? Did seeing an independent outpatient practitioner prevent them from going to inpatient psychiatric, you know, 4 times this year? Instead, they only went once. You know, that's a significant healthcare dollar savings. That we could probably look at those. Self-report, I know Magellan sends patients surveys. How is your practitioner doing? Are you satisfied with the work that they're doing? We get reports from them showing how we're doing. We could, some system I guess could, sometimes patients are happy to report you know, if they're happy with the service, they're happy to report, you know, I'm happy seeing my psychologist. They're mortified sometimes that I have to go through long clinical reviews to continue treatment when they really feel like they're benefiting from it, and they feel badly that they know that we as practitioners have to be put through that. I mean, it's not a very conducive, clinically appropriate kind of system to continue to do good work, but we do. I just want to echo, you know, everything that Dr. Silverman said, that the growing trend in our association of psychologists opting out of insurance companies. It's a huge problem, opting out of insurance panels, the administrative burdens, not getting paid for administrative costs, administrative activities, inadequate reimbursement. You've heard all these things before. And the workforce shortages. The problem I just want to sort of emphasize also is that as I was supposed to be on a phone call with SAMHSA, the Substance Abuse and Mental Health Administration. Vermont is one of 8 states who are being piloted to be part of some, I don't know exactly what it is. I was supposed to be on a phone call this afternoon with them. And problem is that there's going to be a lot more with the DSM, the Diagnostic and Statistic Manual, being updated in May of 2013, offering new diagnoses, this push for parity, this push for integrated care, all this stuff. We have an access problem already, and then we're going to be pushing all this other stuff down the pipeline. We're really going to have an access problem when some of this stuff trickles out. So we really need to look at the workforce shortages. And one of the ways I think that we can do that, as I have down in the solutions section of my bulleted points here, expanding the scope of practice for various practitioner levels. So in the medical system, as far as I know, you have MDs, you have nurse practitioners, you have LPNs, you have physician assistants, and some of these practitioners, mid-level practitioners or entry-level practitioners, can do some of the things that MDs can do, and MDs do some of the things that maybe nurse practitioners. And so there is that trend in medical systems, and I think there ought to be that trend also in the mental health system as well. And I think there's still a lot of scope of practice issues, turf wars. There's master's level clinicians, for example, in Vermont or across the country. If they're masters of psychologists, they cannot be reimbursed by Medicare, but masters of social work can, and doctor level psychologists can. That's an access issue. That's a scope of practice issue that ought not to continue if we want to increase increase access. Same thing with prescription privileges for psychologists. There is a movement that's been going on for quite some time with doctoral level psychologists who have had significant additional training in psychopharmacology and physical medical systems in New Mexico, in the armed services, and in Louisiana. There are psychologists who can prescribe and can do what Dr. Silverman mentioned is in terms of an integrated care model, being able to manage some more, in a more integrated way, manage more of the patient's issues rather than fragmenting them out to see a psychiatrist, a psychopharmacologist, a primary care physician, a nurse practitioner, a psychologist. You know, it just gets to be too much. So there's different ways, I think, that we need to be aware of that we can offer a solution.
Could I ask a question?
Yeah.
On your solutions list, you've got distinguish between services provided by designated agencies, ACOP, CMHs, and private practice. Could you bring that to life?
I was thinking, it was sort of redundant. Again, I put this together in like 10 minutes this morning, but I was thinking in terms of there is a difference, I think, and in distinguishing between when a person needs mental health services, what systems, mental health systems, are they being filtered through? And there is a difference, I think, when someone's going through a designated agency, an integrated care model, a primary care medical home model where there's co-located psychiatrists or psychologists in the medical practice, and then there's private practitioners. And we really need to do, when we're going through this reform process, I put that in there because we really need to be aware of what the differences are. If I went to see my primary care physician yesterday in Stowe, and I asked him about, you know, I said to him, maybe I shouldn't share this, but I said to him, are you under pressure through the community health system that we have in Lamoille County to refer within, to have a patient that you see in primary care go see an in-house counselor or clinician for mental health services? He said, absolutely not. We're not under any pressure to do that. We can choose whoever we want. In fact, we prefer to refer outside of our community health system. So independent practitioners are really a valuable player in this whole system, and I would hope that when we go through this reform process, we would be mindful of what the differences are between a patient. Let's say Mr. Gobet needs to see a psychologist or a psychiatrist. Do you want to call your county hospital and see whoever's there? Do you want to have a choice of different people you can see under this new system? I would imagine you want to have a menu of options, and you want to be aware of what the differences are, rather than just sort of, I think, streamlining everybody into the same system.
Can I ask come back to your point about scope of practice and your medical analogy of mid-level practitioners and picking up different skills? In global health, this phenomenon is called task shifting. And it's based on not using a degree as a surrogate for your skills. So it says more that you should be tested for your competencies, and then you should be allowed in the scope of practice to do what you're good at, regardless of your degree. Vermont is very interesting because of the collaboration among the different licensure mental health professionals. So are you implying that you think we ought to be going more towards a competency-based system rather than a degree licensure system that we currently have? There is a lot of talk about that internationally. I'll give the example of cataracts. Currently in underserved areas, people are trained just to do cataract removal. And if you can show your competence in doing that, then you can do that. If you're a doctor, an ophthalmologist, an optician, or an eye technician. Are you saying that in Vermont, you think if we were more to look at skills and competencies rather than which degreed person is providing them, that would be a good route for us?
It sounds like that's the direction things are going anyway, but I'm not so sure. There is a value, I think, to the degree-based system, but there's a value to a competency exam. I mean, it seems to be the water's getting quite diluted as time goes on. So, I mean, I'm not familiar with this competency-based system that you're talking about, but it sounds very much like the direction things are going. anyway, not that I promote that, I'm just not familiar with it. It just seems like you're talking about something that's happening.
It's happening globally, not so much in the US.
No, well, not so much in the U, but it sounds like it's coming, it's going now.
Well, it's a different way to do things, and certainly would, in a sense, be in the spirit of the kind of interdisciplinary, multidisciplinary collaboration that has been described in the presentations thus far.
Are you at a point where you'd like questions in
Yeah,
general
I'm
from
fine.
us? or-
The rest of it's just, the only thing I think also one thing I wanted to mention in the previous question to Dr. Silverman was the ratio of mental health providers to patients nationally compared to Vermont. We can find that information. But an example of parity being, there was a bill that came up in the legislature this year that Representative Donahue was the lead on, I think, and it has to do with copay parity. So that would be an example of how parity is not being implemented. And that's why I believe that bill was presented, because that's a serious issue. It's still being debated, and I think it's still up. Maybe it's going to go into next year or something, I'm not sure. But that's an example of the parity question that you had. But I'm done, yeah. I'm just here to have a voice for the Vermont Psychological Association and private practitioners.
Well, since you have a specialty in alcohol drug counseling, and we know in the state we have significant substance abuse issues that we've been trying to deal with. Tell me more about how you feel an integrated system, either in those people who you see are in harm reduction with Suboxone or methadone, or those that are just trying to stay clean and sober. How can we integrate our public and private psychological systems to better serve that population?
The best way, I think, and I've thought about this, I talked to Barbara Samaglio of the Department of Substance Use, the ADAP, and I met with her last year, and I think the best way to do that would be through education initiatives. One thing I did in a former life in New York City was to train primary care physicians on alcohol and substance abuse screening and intervention, treatment, and I believe that there's a huge need for that, and if we can get more psychologists trained on substance abuse issues, more substance abuse clinicians trained on mental health and physical issues, more doctors trained on alcohol and mental health. I mean, just it doesn't have to be an extensive thing, but just some basic training and educational offerings to help everybody be on the same page and at least be aware of some of the basics, or maybe a little bit beyond the basics. I think that would be one way to ensure that. Does that answer your question?
Yeah, that helps. I'm just trying to, people come out of a facility either after achieving some facility-based sobriety, or they get on a harm reduction program, Suboxone and methadone, and we know there's not good integration of what we do next to keep them in recovery, and that's the key. Whatever treatment plan we put in place is to keep that recovery going, and we just know there's not good integration there, and it's a problem.
Yeah, I think from my perspective, it has to do a lot with the results we had in training physicians in New York, and all the major teaching hospitals in New York was, I think, significant, because with addiction, it's very slippery, slick, manipulative kind of thing, and to have somebody who's trained in, picking up on some of these subtleties in addiction, it's very easy to want to believe everybody and want to treat everybody and help them and prescribe this and do this, but to have a little bit more expertise in the nuances of addiction, I think is just, that's my drug and alcohol counselor hat. I mean, that's part of what I do, and that's extremely important. So the primary care physician and the nurse practitioner and the psychologist who's not trained in addiction, having a little bit more skill in helping that person stay in recovery, because they can pick up on the signs of where they're kind of sounding a little dodgy and stuff, because the temptation is, and also people are burned, a lot of people don't like to work with addictions because there is so much of that stuff. I happen to love it personally, but having the additional training on that, I think would help reduce the burnout or the frustration that people feel with that particular problem.
We all set? Todd, good?
Yeah, I'm good.
Karen?
Good.
Well, thank you very much.
Thanks for having me.
Appreciate you getting to the top of your agenda for today.
Thank you.
At the last minute.
Thank you.
I think last, but not least, and I'm not sure how to say it,
Rilla.
Rilla Murray, from the National Association of Social Workers,
I'm gonna,
Vermont chapter.
thank you. I'm going to sit in this seat because I'm short, not be leaning forward. By the way. I handed you a document that has a lot of ideas in it. First of all, I'd like to say that I am a social worker and that I'm the executive director of the state chapter of the National Association of Social Workers. I am not and never have been a clinician, a clinical social worker. Many clinical social workers are members of our organization, and I have had a real education in the last 5 years in my position about some of the realities that have already been talked about today. But my own background is in systems and advocacy, and so I'm going to turn a slightly different lens on these issues today. But not surprisingly, I think I'm going to come out in some places that are very similar to what we've heard. I'm just going to take a different route to get there. First of all, I'd like to just give you a picture of where social work is in our system today in Vermont. Social work, as you know, is a field that's much broader than mental health, and it's much broader than medical care. Although those two fields within social work comprise the vast majority of social workers. And social workers are the single biggest group of mental health providers across the country. So there are many, many, many clinical social workers doing mental health and many in medical care, working with patients around serious medical issues as well. There are a total of about 650,000 social workers in the country. It's hard to know how many social workers there are in Vermont. We know we have about 1,500 licensed clinical social workers. But as I think it was Alice said earlier, that's a list of people who hold licenses. And I could name names of people who hold licenses who are in administrative positions in state agencies and so on. They aren't providing clinical services. So knowing that we have 1,500 tells me virtually nothing except that fact. Clinical social workers are salaried employees in the same range of organizations that's already been mentioned: hospitals, mental health centers, community health centers, primary care, rehabilitation, home health and hospice, the whole gamut. Many are also what I want to characterize as small business owners. They're solo practitioners. Or maybe they're in a small group, 2 or 3 people who share rent and share space and things like that, and they have some kind of a group arrangement. As small business owners, they have all the problems that small business owners have, including how to find affordable health insurance.
How to find what?
Affordable health insurance.
I don't know if you heard that, it's been a problem.
Yeah, it's been here and there, here and there. No, I get calls all the time about why doesn't our national organization have a health insurance program? I can't find health insurance. Regardless of where they're employed, the licensed clinical social workers who are doing clinical work are providing evidence-based assessment, diagnosis, and treatment to a group of individuals, adults and children, all ages, families, couples, groups. And their patients present with a wide variety of problems. As Alice said earlier, there's no reason to assume at all that the patients of private practitioners or of social workers are just, sort of worried well. There are some very severe problems that families and individuals present that they're working with. And many of these clients have serious medical comorbidities, such as obesity and diabetes and so on. This is not a surprise. I think far and away, if we think about what are the things we might do here that would promote the integration of care so that it is patient-centered. I think one of the things we have to look at first and foremost is the access issue. Okay, so we've all landed on access. This is a huge problem, and I'd like to take it apart in a slightly different way by offering some observations about how I see this. I really believe that social stigma is the root cause of our access problem. And it's also the reason why we have a disorganized, diagnosis-centered, disconnected system of mental health services. At base, I think that our culture is one where we're willing to accept and we're willing to seek care for conditions we think are fortuitous. Okay, we're not to blame for them. Had a heart attack, oh my God, he's got to be taken care of. Had a broken leg, these are, you know. But when it comes to mental health concerns, there is a pretty widespread stigma that keeps people both from seeking care and really, I think, has inhibited our delivery of health care because we perceive it to be a sign of personal weakness. I know this is starting to change, and I am thrilled that we're starting to change in this way. But we still have a load of stigma, and that makes it very hard for people who have problems to come forward. So even as we try to fix access and integration and so on the system side, and move away from sort of second-class citizen, second-class services in mental health, we still have to kind of bring folks forward with the assurance that this is part of who they are, and it's just as fortuitous in many ways. We know, based on health services research done at Harvard, that probably 50% of patients walking into primary care have some kind of mental health problem that's underlying or is at least related to their medical care. And it was mentioned earlier about people who come repeatedly for types of complaints that could be labeled psychosomatic. I mean, those stomach pains are real, those headaches are real, but maybe nobody's ever asked this patient, what's going on in your life? And it's safe because we don't want to come in and say, you know, I'm falling apart mentally, I cry all the time. It's much safer to say I have headaches. I can't help the fact that I have headaches. You have to help me. So this is, I think, a huge problem. And so it's incumbent in terms of dealing with this aspect of the access problem, the reluctance to use a system and our heretofore reluctance to really integrate mental health, is to normalize the idea that mental health is part of overall health. With each of these observations, I have some specific recommendations that I'll just kind of go quickly through. And I know some of this has already started, but I think it's important to make it normal to look at mental health, no matter why the patient comes to the office. And it doesn't mean that on every single visit we need to do a screen for depression or anxiety, but I think we should be expecting that in medical care, primary medical care, and maybe even emergency departments, that it be part of the assessment, the initial assessment of a patient. And if there's nothing there, there's nothing there, fine. But we need to make it normal, not just for ourselves, but for patients to understand this is another facet of who they are. Secondly, I think I'd like to second the idea of creating some kind of financial incentives for co-location. And by co-location, I'm using that very broadly, either someone in the practice, like a psychiatrist, psychologist, social worker, mental health counselor, drug and alcohol counselor in the practice on a salary, or maybe with an office just down the hallway. But so that because people believe it's okay to go to a doctor for medical care, and if they get this more well-rounded care, in the meantime, there's less stigma associated with it. They start to believe it's part of who they are. So that's gets to, from a very different place, some of the same recommendations. The second one is that once an individual really does recognize that they need some kind of help with a psychiatric or an emotional problem, the path we put in front of them would test the most emotionally sturdy among us. It's an obstacle course. And for example, the first issue, I think it's been mentioned before, because of budget cuts, the most visible part of the mental health system has been reduced. That was the community mental health centers. So there's not as much outpatient care available, especially for adults. So there isn't a real visible place to go. Some people might talk to their medical providers about it. For the privately insured, insurance companies provide a list of in-network specialists in mental health and substance abuse. And there's been a huge issue in the past, it's now getting better, about the validity of those lists. Okay? We don't have to go back through that history. The lists are getting better, but still they're just lists. The private sector works like most small businesses. It's word of mouth. It's maybe some discrete advertising. It's, getting listed in a directory of providers, or maybe adding your profile to a website. But there's nothing really visible for a person who's looking for help. Typically, a person who is in crisis has to make a series of phone calls to people who are on these lists, and many of whom, because the list doesn't tell you this, have closed practices. So, one or two of those phone calls, and somebody who's pretty close to crumbling anyway is going to stop calling. And they're maybe going to turn to some other way to deal with their crisis. Okay? The weight of stigma, which in an individual translates into a feeling of shame, really gets in the way. And somebody who's emotionally fragile really can't handle the way we make them get help once they recognize the need for it today. It's very, very difficult. Another reason the sort of directory approach has failed, that I think is pertinent to the integration of healthcare, is that medical providers would prefer to refer their patients to specialists or others that they know and that they have some reason to believe is the right person for this patient because of the diagnosis and maybe a matchup with personality, but certainly a matchup with expertise and so on. There's nothing wrong with that. It's not any different than wanting to refer somebody to a surgeon. We want to know the surgeon and know that that surgeon does good work and is particularly good at the type of problem you're referring the person for. The problem is that most physicians don't know as many mental health and substance abuse providers as they do other physicians in specialties. So one thing that we could be thinking about is figuring out ways to make that a better connection. And there have been efforts done. I think they've been too static. They've been, directories and even an online directory have been out of date. But everybody in this picture needs help. The patient who's looking for care needs help. The medical provider who wants to help make a referral needs help. And the mental health and substance abuse provider needs help to get the referral. So I actually think that it would be very useful to create a dynamic system, a kind of a real-time, all-payer referral and scheduling system. Some people think it should be statewide. Maybe it should be. There's no question it would have to start on a smaller basis. But I think if a physician could say, talk therapy is very effective in dealing with some of the symptoms of depression or anxiety that you've talked with me today about, and maybe I'm going to give you some medication, maybe not, but I'd really like you to choose a therapist and at least talk with somebody about these concerns. There's a certain legitimization that goes on, and if that physician, before the patient leaves the office, if that referral could be completed, it would make a huge difference. It would get that person into care. So we need some better way, and it includes helping physicians get acquainted with mental health and substance abuse providers and what their specialties are. The third observation is that cost sharing contributes to the access problem, and I think Rick mentioned this too. H559, with thanks to many, but including Ann Donahue, provides now that copays for primary mental health and substance abuse should not be any higher than copays for primary medical care. In the next year, we'll be going through a process of defining these things and writing rules. So we'll really get into the sausage in the next year. But when this is implemented, I think this will go a long way toward improving the openness of patients to use services that have been identified as possibly useful to them. When you go to one specialist that maybe you're going to see once a year, okay, I go to a dermatologist and she checks my freckles and moles and gives me an update on where I am with skin cancer once a year, and I pay a $50 copay. Okay, that's once a year, and I can swallow that. But if I'm going every week for a couple of months or 3 months, those copays add up very quickly. And we had a lot of testimony and correspondence with the legislature this year with case examples of people who drop out of therapy because they just can't afford the copays anymore. And it presents ethical dilemmas for providers. There are many horror stories. So doing something about copays is very important. I'm not sure that I would have chosen the route that we have right now, but I'm happy we have it and I want to move forward on it. I'd actually like to recommend that some consideration be given to forgiving copays for mental health and substance abuse treatment when referrals are made from medical settings, so that we reinforce the idea of integrated care. The next observation has to do with the workforce. You've heard a lot about that. We know that our workforce is currently inadequate because we have incredibly long waiting lists at public centers. We have closed practices. We have people who have very little room to play with their schedules in the private sector. The Act 129 Task Force reports for years have been going to the legislature and reporting how many people we're seeing, and the last one I remember said we were probably seeing 1 in 7 in mental health. That's the commercial insurance population, and compared to a number nationally where we might expect that 1 in 4 would have a diagnosable condition. Now that's very different than demand for care from 1 in 4. Somebody could have a diagnosable condition and be functioning just fine, going to work, supporting the family, might be living a life of quiet desperation, but is not seeking care. So it's not necessarily 1 in 4 are lined up outside waiting for care, but in terms of the global potential demand, it's much bigger. As we said earlier, the workforce data that we have doesn't tell us much except who's paid a fee and met the requirements to get a license and has kept it current. I think the biggest thing we have to look at with respect to the Vermont workforce is the demographics. Social workers are among, they're significantly older as a group. And they also enter the workforce at more and more entering the workforce as a second career. So they're not not as many of them are 23 years old when they start out and have 40 years ahead of them. Some of them are coming in their 40s and maybe would have 15 or 20 years. In 2009, the average age was 49, and about 60% of them nationally were over age 45. In '07, I did a survey of the licensed clinical social workers, and the vast majority of whom reported being in mental health and health, and 40% of whom stated their intention to retire within 5 to 10 years. That was 5 years ago. I think a bad economy has probably delayed some of those retirements, but they're coming. They're coming. And social workers, I mean, we're going to have fewer plumbers too. This is just the baby boom retirement wave.
We have to solve that too?
I was counting on you.
Absolutely.
Well, all
Wow.
I'm saying is that this workforce problem, much of it, is way beyond. I mean, there are huge shifts here. So not only are social workers and other mental health professionals retiring just at a point where we say, hey, you guys, we got a deal for you. We want to, do a better healthcare system, integrating mental health. They're starting to retire. The other thing that's happening is with this same demographic wave, the Bureau of Labor Statistics is predicting that we'll need 25% more people in the workforce than we have now to deal with the old people, with the needs of older people.
So the people who are
Don't
would be
ask it.
treated or
Don't
getting-
ask it.
or-
No, it's not a one-on-one. Although I'd like to say I hope somebody's there to take care of me when I need it. I think we can think about lots of good ideas with respect to the workforce. A couple that come to me that I think would have an immediate impact on improving our systems and getting people to participate who are not now participating. There are many private practitioners who have bailed out of insurance or they're very restricted in what insurances they take, and it's for the reasons that have already been cited. Is we need to pay providers for all aspects of their care. This is the care they provide, the collateral contacts and so on. This is particularly critical for those who work with children, because to work with a child means collateral contacts. You can't work with a child without working with parents or maybe teachers or somebody else in this school, the principal or counselor. So we need to be paying people for the work they do, whether it's a separate code or whether there's a global payment or however, but we need to recognize that the time face-to-face in a session is only part of the work that's done for that client and with that client. And I would add my voice to the importance of attracting qualified folks to Vermont. We don't have loan repayment for social workers. There was an attempt to get that that failed about 6 years ago, I think, in the legislature. But I think in addition to loan repayment, I know there's a lot of talk about loans right now, college loans and grad school loans. I think there are other ways we could make Vermont even more attractive. We could pay for the clinical supervision they have to have before they get a license. Provide it for them or reimburse them for it. We might be able to find ways to assist with the establishment of a practice if it's co-located with a medical practice. We might want to make part of the deal compensation for the continuing education they all need so that they can stay fresh with research about effective practice. So I would say of all those recommendations, the three that I think are most important in terms of having an impact on the integration of care and being able to have a patient-centered approach are to normalize mental health within the system as much as we can. The second is to look at the potential for a real-time referral and scheduling system that is significantly supported by opportunities to get to know the skills and expertise of the mental health and substance abuse providers. And finally, to assure that the payments to providers participating in the system recognize their full contribution to the care. I would like to say that social workers nationally and certainly in Vermont are extraordinarily excited that we are on the cusp of universal access to health care. This is a social justice issue in our view, but it's also something that is incredibly important for building healthy communities. And I don't mean from a population health point of view. I mean healthy kids who grow up and become good citizens, et cetera, and the community is functioning well. This is a critical part of life, and we're very supportive of your work and very grateful for you taking on that demographic problem and anything else. I'm happy to answer questions. Or,
thank you. Con, you want to go first?
Yes. One of your, well, two observations. You entered the world of how do you get people, identify people and get them in. And you basically, your position is that it's a personal weakness, therefore stigma occurs, and therefore. Then you made a recommendation, which was really kind of interesting, inpatient assessments at the primary care level.
mm-hmm.
Does that happen anywhere in Vermont at this point?
Yes, I think in much of the, at least it's been discussed, in some of the blueprint practices and so on, part of the discussions I've been involved with have included the use of depression screenings. It may even be a measure, a performance measure that's applied. I think the more we treat those kinds of things as just a normal part of the assessment, just like, you know, heart, lungs, etc. Your emotional state is just part of this assessment.
So basically, as the blueprint gets stronger and bigger, this hopefully will begin to take care of itself a little bit.
It can, yeah. And I think we are moving in that direction. We should probably be looking for other ways to normalize as well.
Great.
Alan?
Thank you.
I'm all set. Karen?
Good.
Well, thank you very much for
Thank
coming
you.
today.
Appreciate it.
We appreciate it. Georgia has a couple of announcements she'd like to make.
That Al won't make. The first is, we've spent a lot of time talking about workforce, so I just want to make sure that all the folks in the room are aware that David Reynolds at the Department of Financial Regulation is heading up the workforce strategic plan that the administration is doing, that they then will present to the board for approval. So I think it would be important that a lot of the messages you've given us today that you also give to him as they're working on it. So I wanted to make sure you knew that. And the second is the Act 129 task force was also mentioned that was eliminated this year, in part because the Green Mountain Care Board actually is convening a mental health technical advisory group. Ina Backus, who's going to wave, is leading that for us. That group is going to begin in earnest in the fall. We want to make sure that because it's a technical advisory group, we actually have things that the group can respond to, rather than just, you know, random ideas that come up. So if anyone is interested in learning more about that, just contact Ina in our office and she'll give you more information.
See, you do it so well. Why would I ever attempt to move in on that?
I'm sure that's it.
Now we have public comment scheduled. Anyone? Representative? Sure.
Thank you. My name's Ann Donahue. I'm the editor of Counterpoint, which is the state's mental health newspaper. And I did want to make a couple of quick references around two topics. First of all, the way that your task maybe has increased this year in terms of mental health. And secondly, an issue a lot of people just say, what is parity? What's that supposed to mean? I think this year, in terms of what happened, both from the administration and the legislature, we have made some of the greatest steps backwards in the understanding and implementation of integrated care and parity. And I can give you just three quick biggest points. First of all, we created a new mental health system In doing so, we did it with zero input from the healthcare system. Does it mesh with what we're doing in healthcare reform? Does it support integration? Who knows? Because it wasn't asked. And it was not part of the testimony or the input or the design of an entire new mental health system of care. Secondly, in the healthcare reform bill itself, we created an independent mental health ombudsman, right back to the belief that separate but equal works. And third, we have gone on a track in which we are apparently oblivious to the concept that a state-of-the-art acute care hospital would not be an oxymoron with a hospital that's not co-located with a medical center. 12 years ago, Public Oversight Committee denied a certificate of need to Fletcher Allen Healthcare for proposing a psychiatric hospital that was not completely co-located and integrated with a medical center. And once you construct something, you're locked in. So you lock in an archaic model for the long term. That's a pretty big step backwards. So what is parity from my perspective? It's simply equality in access and quality. And my own notes, actually, you've heard a fair amount about. Access barriers are the resource piece. Financial, we looked first as a state years back on private insurance parity. That's still not achieved. We still allow completely separate insurance policies, products between mental health and physical health. And reimbursement equity, you've heard a lot about. And then the second barrier, of course, is stigma, which is an ongoing as well as historic isolation. And really, the only way to address something like that is through affirmative action, not just saying, well, we're going to try to do it from henceforth. The second piece on parity equality is the quality part. The first piece of that is applying the same Institute of Medicine standards for quality, patient-centered, et cetera. And the Institute of Medicine created an entire quality chasm series on the applicability of the Institute of Medicine standards to mental health and substance use care. And I don't think a lot of people have paid much regard to it. But second, the final point is that quality in care in mental health absolutely requires integration with healthcare. You can't provide it, you can't say you're providing quality mental health care if it's not integrated because of the interrelationship in terms of illness and wellness between the two. You know, and there's just tons of research. You know, you've got 2 to 3 times the likelihood of, you know, cardiac issues, problems if you have a history of depression. Things that a lot of people aren't even aware of. My likelihood of osteoporosis is significantly higher because of a history of major depression. You know, things as small or as large. You simply can't say you're providing quality mental health care without integrated care. So, those were my comments. Thanks.
Thank you.
May I ask a question?
Sure.
You were on the House Health and Welfare Committee.
That's right.
Were you the lone holdout on that bill?
There was a holdout on...
The new facility?
Oh, we weren't, the bill doesn't require, the bill doesn't require co-location in any way. The House bill did. It was the conference committee.
Okay, I just
That-
wanted to know
yeah.
where the problem lay. Okay.
Right. But that was based, I mean, the administration came out in its press release in December saying we're putting it on state-owned land in Berlin, which is a landlocked, behind the Berlin Mall piece of land. You know, you got to go a mile around to get to the hospital. So,
And just a question about the IOM report.
Yes.
That addresses mental health quality issues. Would it be useful to us in terms of this question around outcome?
Yes, it includes, it's pretty comprehensive, and it's how it's applied to, and the same standards applied, obviously adapted to the specifics of diagnosis in the same way you would adapt it for any other, sub-component.
I somehow missed that report. Do you remember, is it a new report or a couple of years ago?
Oh, it's been a couple of years now. I think it came out a couple of years after the initial quality chasm. It's not a report, it's a book. It's a whole, yeah.
Thank you.
Can I ask you, Ann, about, again, the primary care clinical model that has been in place now since 2007 or 8, I believe, is the blueprint.
Right.
The blueprint has phase 1, which is which provides a utility called the community health team, which is exempt from cost sharing, which does include some level of mental health access. And then phase 2 is the primary care specialty integration. How do that's the clinical model, and we don't need to talk about how well the financial model has lived up to what we hope to achieve with the blueprint and the patient-centered medical home. Do you feel that's a step that we're taking towards more parity and less stigma?
I think, yes, I think it is a positive step. It's not, there was a reference to it started at the identification of what measures should be used is just occurring now.
Right.
So
that's the performance. And
right.
We are
that's right.
focused on performance and how we design the system.
Well, this isn't even performance.
Yeah.
This is the measures of what the primary care doctors should be checking.
Sure, that's the NCQA measures.
Right.
Yeah.
That's right.
But we're more interested in how the system is designed to improve the value, which means the patient experience.
Right.
Okay.
But that blueprint piece, as far as I've seen or know, the public mental health piece, I mean, there's the non-integration health, but then you've got this sub-piece of public-private integration, which, again, was not even looked at in our new system of mental health care created this year.
Thanks.
Thank you.
And of course, you are the new Act 129 task force, so that adds to, you replace it.
Yeah, Ina.
No, the responsibilities.
We're kidding.
No, well, but it is not the subgroup. It is the Green Mountain Care Board.
We're just kidding.
That, okay, all right, because, yeah, that we're reassigned the responsibilities that the task force had.
Kind sir.
Yes, Ken Libertow. Since a comment was made about a book that I did write, I have to say, listening to a lot of the conversation, I think about all the mistakes I've made in the last several decades. But I did have a good title. It was called Fighting for Parity in the Age of Incremental Healthcare Reform. And part of what we're really beginning to focus on is hopefully removing the word incremental, which is very important. I just wanted to take a minute to say a couple of things that relate to, I think, what we've learned, or perhaps what we may think we've learned about parity. Just so you understand, I assume all 5 people sitting up front have health insurance. Not all of you would have it probably through the private sector, but most of you do. If you were sitting in Vermont in 1997 up there, you would have had in your policy, even if you took the best policy offered in the state, a $10,000 lifetime limit for mental health and substance abuse services. This in and of itself was a profound discrimination that greatly skewed treatment and only furthered, stigmatization, etc. So getting to the point of passing a piece of legislation that equalized the lifetime limit was a profound piece of progress in January 1st, 1998. So that's partly what, when people say the parity bill, a lot of people don't know what it means. The second thing that's very important is that it covers all conditions in mental health and substance abuse. And I relate that back to an issue that you're going to have to resolve, or, you know, sometime in the next months or year, which is, what does the benefit plan look like for conditions? Although it isn't well known in most states that say they have parity, they have what I would consider a lack of parity. They just cover certain conditions. That's very different than the Vermont bill. And it's also had, I think, a profound positive effect to cover all conditions rather than specific conditions. And the example would be if you had cancer, the way some parity bills are written, and there was even a suggestion in 1997 we did, that was our parity bill, you get one opportunity to see a clinician for a certain major mental health or substance abuse condition, and that's it. You wouldn't do that for cancer, and you wouldn't do that for lung disease, but that, you know, it was even under discussion. So I think that one fundamental question that will come back in some ways, it's like a revisiting of parity, is what will the benefit design look like for mental health and substance abuse? I'll just sort of end with that point. The second point, which I think I would say we learned, is that the incredible power of the parties that are at play here in over 20 or 25 or 30 years, I don't think it's any revelation that the insurance industry is one of the real power players in not only shaping, but I'd use the word dictating, what really happens in medicine. It's certainly true in the United States, and to a large extent it's been true in Vermont. So that's a new challenge. I think Ann Donahue is right, and sort of just being sensitive to the fact that regulating this industry is a mammoth undertaking, that we've largely been unsuccessful. So that's the kind of the lesson that I bring to you. I was involved with two very good pieces of legislation. One led to the 129 group. Both were regulatory pieces of legislation that were actually in their own ways profound and way ahead of their time, trying to regulate the managed care industry in Vermont. But this certainly is true that in all states, and Vermont included, it was very hard for states to regulate the healthcare industry, particularly the insurance industry. And I can warn you that unless you take this very seriously, despite, you know, even what some of the expectations for full coverage for mental health and substance abuse, the insurance industry will, in its own way, be able to manage, micromanage, and mismanage systems of care in a way that will really hurt access to care. One of the things the parity bill didn't address, purposely in some ways, was the payment, or couldn't, was the whole question of reimbursement. So it's another tool that the insurance industry has had to control some of the very issues that were before you today. And very happily, you may have an opportunity to help address that issue when, in the last 14 years since the passage of the parity bill, it continues to be a battle, and it's led to some of the barriers that we've been talking about. So I think in summary, you know, there's a lot to learn from the past. I think I remember one incident where, after great pleading, an actual fine was levied by banking insurance department in the 14 years since the parity bill passed. It was a small fine. It happened to be about 5 or 6 years ago. I am truly profoundly disappointed that we just haven't had the gumption and the political will in the past setup to really deal with poor behavior on the part of, in this case, the insurance industry. And if that continues, no matter what happens in the next few years, a great deal of rhetoric about reform will melt like snow in, I better say, in February. It used to be May or April. So thank you very much.
Thank you.
Thank you very much. Is there anyone else that would like to have the floor for a little bit? All right, well, that ends our meeting. Thank you very much for coming.